Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name is Mike Sullivan and I'm one of the instructors with Valor Medical Services. In this presentation we'll be discussing toxicology and a little bit further down into opioids. Now, when we look at the National Registry objectives as they've outlined them for this module, we're going to talk about some of the common synthetic stimulants and natural or synthetic THC and some of the signs and symptoms we get from that. Also the effects of these stimulants and THC. We're also going to get in deep with common opioids, recognize the effects of these opioids, and explain the common treatment options for a person experiencing an opioid overdose of some kind. Now, I'll tell you, I've been around in EMS since about 1993, and my background, I've worked from 911, I've worked in a facility transport for a little while, I've worked also on the fire side, and I can tell you honestly, when people talk about, the opioid epidemic and the opioid crisis, these are some of the numbers we're starting to see nationally. These are 2019 data set, was the most current I could come up with when I was putting this together, comes from the CDC. And when we look at over 70,000 deaths in 2019, over 49,000, almost 50,000 of those are opioid involved or opioid related. So we can look at that and come up with a pretty good idea of where is the problem and what do we need to deal with. And we'll also talk a little bit about some of the different things we're seeing with opioids out there in the street in this day and age. They're more common than many providers think. I'm sure everybody has seen some, but I know many areas we're starting to see this really kick up more and more right now. Now, overall, as a general response, we look at what does EMS do on most toxicological emergencies or overdoses. First off, we've got to be very concerned with scene safety. Depending on where the location is, what we're going to, we could have a toxicological emergency. It could be a lab. It could be a drug house. It could be someplace in the neighborhood that people routinely go to shoot up. So therefore, not only could we be dealing with one patient, we could have multiple patients there, depending on if what type of batch they've got, if they were all shooting up or smoking or working out of the same batch of whatever the pharmacological adventure of the night is. If something is bad or something is overdone, we could walk into multiple patients from a bad batch of pills or a bad batch of heroin. So that's definitely a major concern. Again, drug labs, you talk about nowadays, some of the stuff people are cooking up at home or in vehicles or at campsites. Almost any place in the world right now, we could be walking into a drug lab or a clandestine drug lab. And so we have to be aware of that. What's going on in this house? Who is there? What's all going on? Yes, we want to treat the patient, but we also, again, need to be a little bit more aware of scene safety than you might be on, say, the average respiratory distress call or chest pain at the local nursing home. As far as patient care, our primary survey and our, immediate focus is going to be the same as it would always be. We want to evaluate and make sure the patient's got an airway. Are they breathing? Are they breathing effectively? What's their respiratory rate? Is their tidal volume effective? Are they adequately moving air in and out? We'll evaluate their circulation. And beyond that, a lot of our care is primarily supportive care on the majority of responses. Now, that changes in some cases if we have an antidote, say, for example, if we suspect or know it's an opiate base, and we'll talk about some of that. But in a lot of these cases, there's not much pre-hospital treatment we can do. It's primarily supportive care and do what we can to help support the ABCs and get them to the hospital. A lot of it comes into, does the patient know what they took? Do bystanders know what the patient took? Does anyone have any idea what it could be, or nobody will tell us anything? If nobody will tell us anything, then we've sort of got to work a little bit blind. So we'll support our primary survey, our essential life functions, and we'll work from there. Now, when we get into some of the more specific stuff as far as poisoning, again, a lot of our care is primarily supportive. There is a great resource out there, and it's a wonderful asset to us as providers. It's something that we can use relatively easily. One of the best resources around is poison control. Now, I know that from experience, typically they need about the following information. They need to know, if possible, what substance is involved, how much of whatever it is did the patient ingest or did they take, when did they take it, how did they take it, and what does the patient weigh. Now, when we talk about this, it can be anything from the 5-year-old who got into grandma's cardiac medication to the 25-year-old who shot up with who knows what, to the 2-year-old who drank the cleaning solution under the kitchen counter. Generally, these folks at Poison Control have a huge resource database they can evaluate, and they can not only let you know that yes or no, whether this is a toxic dose or not, how it will be a toxic dose, how it will affect the patient, what you're likely to see, how far along in the reaction you are, how long it's likely to take. And so they are pretty much your single best resource. I firmly believe that every EMS provider should have this number saved in their phone. Nowadays, we carry all these wonderful electronic devices with us on our hip. This should be something that is, very quickly able to access, do our assessment, get our primary survey done, try to find out, identify as best we can what we're dealing with, and then work from that with this phone number, trying to come up with a treatment plan. I know in many cases they can actually connect you up from them. They can even three-way into your ER and brief the ER on what you're bringing in and give the ER a lot of information that they're going to need to maintain long-term care for this patient. So again, even if you don't save it in your phone, it's pretty easy to remember. It's 1-800-222-1222. But like I said, ideally, save this one in your phone. It's going to work really well for you and be a great asset, be a great resource you can always use. Because at 3 o'clock in the morning, toxicology is far too advanced and far too in-depth to try to remember and know all of it. Now, there's a few things that we'll see a lot of in the field, and we should have a little bit of information about those specific things. One of the first ones we're going to talk about is some of the synthetic stimulants. Now, a synthetic stimulant, think about it, synthetic means it is man-made. It's not a naturally occurring. It's something that's been created or chemically combined, and it's a stimulant, so it's going to be something that's going to be an upper. We can look at some of the common ones. Methamphetamine, very common these days. Again, when we talk about drugs, who knows who's cooking up what in their back bedroom or in their garage or in their shed or in the trunk of their car. Bath salts have been, relatively common. They were out for a while. I know many states have moved to make them illegal. When they first came out and they were legal, you could buy them in gas stations, convenience stores, and we were seeing a lot of activity with them. That seems, at least from what my perception is, to have dropped down a little bit. We have MDMA. That's more of a, I guess you'd say, a party drug, or a more likely to see it if you're at a function or a get-together, as opposed to just somebody using this on their own. Now, getting into methamphetamine, all sorts of names for it: crank, crystal meth, glass, ice, tweak. You can see picture there. That's pretty good picture of actually what it looks like most of the time. It can be yellowish, it can be pinkish. Typically, this is going to be some sort of crystalline powder, hence the name crystal meth. It can be sold as either shards or crystals. Sometimes it will be, crushed down into a powder or a tablet form, but most likely you'll be seeing the type of stuff you see right there. Now, this can be smoked, it can be snorted, it can be melted down to a liquid in that spoon there and shot up IV. We see it, I'd say, like I said, it's one of the more common ones we're seeing on the street these days, at least in our region. Now, when we get into bath salts, like I said, they were very common for a while. They seem to have backed off a little bit. Things such as Bliss, Blue Silk, Ivory Wave, White Dove, White Night. Again, it can be a powder, it can be white or off-white, maybe in a capsule form. Again, these can be ingested a variety of different ways. Unless somebody tells you that, hey, they know what the patient took, or they have some idea what the patient took, you may or may not know whether you're dealing with crystal meth or bath salts or what. Now, MDMA is the party drug type thing. Goes under the names of ecstasy, X. Sometimes you'll hear it Skittles or Smarties. These are typically found in some type of tablet or capsule. They can be in liquid drops. Typically, it's going to be snorted or smoked. They may just be ingested orally. Again, we look at them. Now, those tablets there don't have any markings. Anytime you see tablets with extremely strange markings on them, things that don't seem like they belong, could be popular culture symbols, things like that. I've seen them with different logos, designs off the internet. And it's like, okay, we know that that pill or that tablet is not something that was made by a regular drug manufacturer. It is something that's actually been pressed in a back room or in a drug lab. And so it's like, if you see something that's, let's say, it looks like a Smurf, or like I said, common pop culture symbols, things like that, can definitely indicate that you're dealing with some type of MDMA. Now, any of these synthetic stimulants are all going to pretty much produce a lot of the similar responses. And sometimes it may not even be necessary that we know which one of the above we're dealing with. If we start seeing this, we can have an idea that, okay, it's some type of stimulant. We're not sure what it is. They'll present with agitation, insomnia. They may not have slept for days. They may be extremely irritable. They may be depressed, especially if they have been up for days. That can take a great toll on their mental health. May present with paranoia. They may be delusional, may not know what day of the week it is. Eventually, this depression can manifest out to suicidal thoughts. panic attacks. These folks will stay up very high for a while, and when they come down with the depression and the suicidal thoughts pretty hard. Now, you can also look at the physiological or the somatic response. Hyperthermia is very common with MDMA, also tachycardia, hypertension. This can lead to all sorts of issues such as ACS or stroke. We may actually get called for a chest pain. And again, you have a patient that you get there, they're extremely tachycardic, they're hypertensive, and yet they're 18, they're 19 years old. They've got no cardiac history, no nothing that would indicate this. And meanwhile, they've got a heart rate of 140 with a blood pressure of 200. And we're kind of wondering what's going on. It's always fair to sort of ask about, could it be something that you've taken, maybe something to stay up, maybe caffeine pills, some type of stimulant. Again, our point at this is we're not trying to necessarily judge them or find out from that standpoint. Our biggest concern is what's going on with their heart, what's going on with their potential for a stroke. Why do they have a heart rate of 140? We need to manage their ACS as much as we can. If they are having, real bad chest pain, difficulty breathing, that type of thing can definitely be a concern. Along with the hypertension that may lead to a stroke, it can also lead to nosebleeds. When you talk about a patient, again, profusely sweating, you see that common with the hyperthermia as well. This may manifest with things that look like excited delirium, which can be a whole nother wonderful thing to have to manage. You may see seizures, dizziness, nausea, vomiting. And again, this can run pretty much in commonality with any of the stimulants. And you can get to even the point, some of the people who go through energy drinks, if they're doing enough energy drinks along with this, and they've been up for a day or 2 or 3 or 4 days, that could also combine. The energy drinks can help increase the manifest of these. So that's pretty much good idea of what some of the stimulants are. Now, let's get into something a little bit more easy to work with. THC. Now, THC, as we may know, is the active ingredient in marijuana. Now, marijuana or THC has been legalized in several states for medical usage and in some states for even recreational usage. THC can present not only in the conventional, what we would think of as marijuana, it can also be put into different foods. It can be candies, it can be gummies. They actually have things that look like gummy bears that actually have a certain amount of THC in them. It can be put in baked goods. I'm sure we've all heard stories about people making marijuana brownies or THC brownies. In some of the areas where it's legal, candies, gummies, baked goods may be sold at various dispensaries. You may even go to some of these dispensaries and get drinks or sodas. You can get marijuana fruit punch or marijuana soda in some states. I know there's actually a couple of brands of soda out there that they've come up with that are actually THC laced, and they have a certain dose of THC in them, and these are sold over the counter at dispensaries in areas where it's legal. Now, if you're in a state where this is legal, again, they may have several different of these put together as commercial, sold, packaged, made. We know pretty much what the dose is in one marijuana soda or THC soda. We know we can read the label and see how much of what is in the candies or gummies that a patient may have ingested. However, if we're dealing with something that's not commercially packaged and made and labeled, we're sort of dealing with a grab bag because we don't know, A, how much is in it, and B, we don't know what else could be in it. Who knows who got creative when they made these? Now, the most common marijuana or THC that you'll see is what you see right there. Marijuana, again, THC exists in nature as a plant, can go under any of those wonderful names there. Typically, it's a greenish-brown mixture of dried, shredded leaves. Some may have stems and seeds in it, depending on how much is in the package. It can be smoked in a cigarette or a joint. It can be packed into a cigar wrapper. It can be smoked out of a pipe or a bong or a little one-hitter. Any of those can be very common. Again, this is legal in many states. It may be ingested orally, again, as we said, in different candies, things like that. And this type of THC doesn't really present us much of a concern or much of a problem. The one where it gets to be a little bit more dangerous, there are many synthetic THCs that have come out on the market under different brand names, and they may look very similar in appearance to natural THC, and the effects may be very similar because they bind to the same receptors and do the same thing. However, it may be much stronger. In several studies, they've actually tested the THC levels between the natural and the synthetic, and you may be looking up to 100 times stronger and more receptor affinity. So therefore, it's going to not only hit faster, it's going to potentially last longer. The other thing is, most of these synthetic THCs are illegal these days. If you're dealing in an area where this stuff is illegal, again, we don't know what else could be in it, what other chemicals could be in it. Unfortunately, the stuff that is, made commercially, legitimately for a licensed, legit business in the areas it's legal, there's a degree of quality control. If you're dealing with somewhere that they're manufacturing this, that it's not legal, it's basically somebody doing it in a warehouse or a shed somewhere, and we don't know what else could have possibly gotten mixed into it. Not a great deal of quality control and recipe management. Many times this comes into pretty much whoever is using it or purchasing it, they have to have a lot of faith in whoever is making it up or cooking it up for them. Now, THC, again, it can be natural, it can be synthetic. Either one can present with impaired short-term memory, decreased concentration or attention span, may have impaired balance, coordination, may increase heart rate and blood pressure, may increase your appetite significantly. As a general rule of thumb, we're not going to see many major side effects from THC. The one that we may see in some cases, and again, is fairly rare, is cannabinoid hyperemesis syndrome. Now, this is a product of heavy cannabinoid overuse. This is going to present with not only cyclical vomiting, vague diffuse abdominal pain, and may be mistaken for a GI issue such as gastroparesis, and may be relieved with hot showers. Now, this would be somebody who, again, not using just marijuana or smoking a joint with friends. This is heavy, hard overuse, possibly if they got into some of the commercial stuff or some of the synthetic stuff, that they really went over the deep end on it because they weren't feeling anything initially, and so they've eaten a whole bunch of these gummies or a whole bunch of these, hash brownies or whatever the case may be, and now we're starting to see, some of the signs and symptoms of this. The only relief for it really and the treatment for it is a little bit with a hot shower. I researched it through Titnally's emergency medicine, and they said, the biggest thing we can do on this is just assist the patient in getting through the symptoms and, assist them with the vomiting and the abdominal pain as much as we can. Again, it doesn't present a major issue. It is very, very hard to overdose, well, it's virtually impossible on natural marijuana. On some of the synthetic stuff, it's still very hard to do, but it takes a little bit of, effort to get there. Now, going further, opioids. Now, some of the common opioids we look at: heroin, morphine, oxycodone, codeine, fentanyl is one, hydrocodone, methadone, meperidine, hydromorphone. That's some of the big ones. There's a lot others out there. Again, roxycodone is another one. And one of the things we see is a lot of these are pills that are available through legitimate pharmacies with a prescription to patients who have had them prescribed to them. And so there's a great deal of quality control of those pills, and whoever's buying them, using them, taking them pretty much knows what's in them. However, there's also gotten to be a great deal of a black market for these pills. And as supply and demand would dictate, if there's a market for something, someone will start supplying it. Now, the next photo here, this was taken from a recent drug bust that occurred in Simpsonville, South Carolina in 2020. And it's, typically the kind of picture you might expect to see from any drug house. There's a bunch of cash, bunch of firearms there, some baggies, all sorts of good things, some, Ziploc bags and everything else. But I really want to draw your attention to those two metal things on the table. If you look, there's one over on the left and there's one on the right. Those two metal machine-looking things there are actually pill presses. And when we talk about a pill press, that pill press is actually designed to make a pill. And it can make a pill that looks, to the naked eye, undistinguishable from one that was created at an actual pharmaceutical manufacturer. And the reason I bring this up is patients who we get may have some of these pills that look totally legit, look totally real, but they may actually have accidentally overdosed because, as you can imagine, the individuals who were operating this location that got busted, they probably were not doing a lot of quality control. So how much of what drug or what opioid is in whatever their homemade pills are? It's a little bit scary when you think about it. Again, our legitimate patients who get their medications from a pharmacy, this really isn't going to be on their radar that much. However, people who buy pills off the street, or people who buy them from friends or black market or anything else, and those who sell those, there's no quality control of what could possibly be in that pill and how concentrated it is. What they're doing is they're making up big batches of powder, and they're adding some type of opioid into that powder, and then they mix it all up and press it into pill form and sell it as legit pills. Now, to understand the potential ramifications of this, the person or person operating those presses, if we've ever made a batch of chocolate chip cookies, and you make these chocolate chip cookies, and one cookie might have 3 or 4 chips in it, and another one might have 8 or 10 chips in it. Well, just imagine that was one of the pills made up by the operators of this facility here, and one had so much fentanyl in it, and the other one had 2 or 3 times that. Would it be possible for somebody to be taking a pill and not realize that they were going to overdose as a result of it? These types of pills, again, the black market stuff, we know it's out there. Law enforcement's been dealing with it. Hospitals have been seeing a lot of it. And these patients that come in via EMS or get found as overdosed, they've got pills on them that look totally legit, that may be 5 to 10 times as potent as what the pill would actually indicate if it was made commercially or in an official preparation facility. One big reason I bring this up with these pill presses is, let's say we go out for a call and we have a patient who's showing signs of altered mental status, unresponsiveness, respiratory rate is severely depressed, and we'll say the patient's name is Susie. And so as we're evaluating Susie, we ask the bystander, Susie, did Susie take anything, or any possibility she could have taken something? And they say, well, she just took 1 or 2 Norcos or Lortabs or 1 or 2 pills, but she's always been able to take that. Susie's been on those forever, and she's never had a problem with them before. Well, if Susie didn't get them from a conventional commercial pharmacy, if she got them off the street, black market stuff, those 1 or 2 could be 5 or 6 or 10. So we need to be aware of that, because the minute we find out that the patient just took 1 or 2, and that shouldn't be the problem, if they're black market, that can indicate there's definitely a problem, and it can be a good point for us to start working on to try to treat Susie for a possible opioid overdose. Again, there's typically not a lot of quality control on these houses, so we've seen some interesting things. We've seen, unfortunately, quite a few deaths of individuals who bought stuff off the street and thought they knew what it was based on its markings, and it turned out that it was actually a counterfeit, and it unfortunately took their life as a result of that. Opioids, as we said, they're one of the most common drugs of abuse today. Prolonged use may lead to tolerance, addiction, or dependence. We actually have opioids within our body normally, that our body produces a certain degree of opioids. It's in micrograms, and we don't normally know about it or think about it. However, if our body gets exposed to long-term opioid use and abuse, if we use them for an extended period of time, our body itself will stop making those opioids. It'll think they're extra and they're not needed. As a result of that, when we go to come off those opioid pills, it can cause a whole variety of symptoms, typically GI symptoms. You may see profuse diaphoresis, things like that. And so therefore, what's happening is the body is getting used to having zero opioids in it after having had an overload of them for a long time. Now, opioids may be synthetic or semi-synthetic. As a general rule of thumb, most of them will act as a central nervous system depressant. They're designed to not only decrease perception of pain, but also decrease the body's reaction to pain, increase patients' pain tolerance, and in some cases, they may be abused to actually induce euphoria, hence where we start seeing people becoming tolerant to them and becoming dependent on them. Now, opioids are not bad in and of themselves. They may be described for acute, debilitating, chronic pain issues. They may be used as part of a palliative care treatment program. Long-term cancers, bone cancers, hospice patients may, again, be on these. They're not, again, in and of themselves bad. However, if they're used long-term, we may see patients start to develop a tolerance to them and have to use more and more, and that's where we start seeing dependence come in. The effects of opioids, respiratory depression is one of the big ones. That's usually the one that's the most life-threatening. They may be drowsy. They may actually have constipation, which when they go to come off the opioids, if they come off very suddenly, will have the exact opposite of the constipation. They will spend a considerable amount of time in the restroom. I hope they brought a magazine. A big pickup for opioids is meiosis, or pinpoint pupils. That's one that we really need to remember in the field, because it can be a great differential diagnosis when we're trying to determine why the patient's altered. We have an altered mental status patient. They took something. We don't know what it is. Typically, if it's an opioid, we'll see meiosis or pinpoint pupils. On the other side of that coin, the respiratory depression, altered mental status, if we see the pupils very wide, very enlarged pupils or dilated, we'll see may well be benzos, may well be muscle relaxants or something else. So again, the pinpoint pupils are a very good sign to look for to confirm your suspicion that yes, there's some type of opioid in play here. May have dry mouth, may have itching, they may be scratching a lot, may have nausea or vomiting, various GI symptoms. Again, the lack of gastric emptying may cause a lot of GI issues for them. The general rule of thumb is these opioids are not a problem until we get to the point of respiratory depression. Now, if someone takes too much of an opioid, whether knowingly, intentionally, or accidentally, in the case of like a black market pill or something that was stronger than they thought it would be, or they're very naive to opiates and they're not familiar with them, we can see the central nervous system depression, which leads to respiratory depression, and that respiratory depression will lead to poor rates, poor tidal volumes, and hypoxia. So our management for these is primarily supportive care. We can support their respirations using a bag valve mask with supplemental O2. We may consider Narcan or naloxone as an opiate blocker. Now, as an opiate blocker, Narcan or naloxone works to block the effect of opioids by blocking the receptor sites. Think of it like you're parking something else in the parking place where the opioid should go, so now the opioids can't park there and can't offload. This can be used to reverse respiratory depression that's caused by these overdoses. It can be administered a variety of ways: IV, IO, sub-Q. It can also be administered via nasal atomizer. It can be administered via auto-injector. Over-aggressive administration of Narcan will produce withdrawal effects. We don't want to necessarily pull all of the opioids out of their system at once. We'll send them into withdrawal. We want to land the plane, but we want to do it as gently as we can. Ideally, we'll go ahead and we'll administer it slowly. There's really no main contraindication in Narcan with the exception of a known hypersensitivity to it. The other thing that we need to consider when dealing with Narcan is it will work fairly quickly, but because it works so quickly, it has a short half-life and it may wear off quickly also. If the patient has taken a significant amount of opioids, they will still be in the system. So we may be able to do wonderful things and wake them up with the Narcan, fix their respiratory depression, they start to come around and everything's fine. They don't think they need to go to the hospital, and 30 minutes later they can go back out on us. So we need to be ready for a second dose potentially as well, and we also need to make sure these patients go to the hospital with us if at all possible. Now, when we look at the packaging of Narcan, there's several different packagings out there. The one there, the first one, is 2 doses of Narcan packed in a little kit. The tip on the end there is what's known as a nasal atomizer device. That's for nasal Narcan. That can be screwed onto the tip of a syringe, and that can be used to administer it up the patient's nose, so therefore we can do it without starting an IV or without having a live needle out at all. The one next to it there is a Narcan auto-injector. It's actually designed with a needle directly inside it, and you actually pull the safety cap off and can administer that into the patient sub-Q or IM, and again used as an antidote for opiate-based emergencies. Moving on to some of the other packaging, the tip there, that photo with the Narcan box in it, that is just the standard EMS Narcan prefill, and it's had a supplemental atomizer added to it. Many agencies carry those little tips and can use them for different medications depending on what all's in their formulary, what all they carry. Over to the right, there's a Narcan nasal spray there. Now those come in boxes, typically 1 or 2 in the package. There's 2 there, and many patients may actually have these at home. I know in South Carolina, family members of people who may have opiate-based issues can actually get these over the counter through their local pharmacy. There is a degree of training required for it, however, it's again, pretty simple training, and there are several pharmacies in most communities that are doing this training and issuing these to people to try to save some of the lives. Again, we've lost 50,000 lives in 2019 with this stuff. Let's see if we can't address this. One of the greatest things is putting the tool in the patient's hands at home. Now, up to this point, most of these devices can be used by lay rescuers, bystanders. I know in many communities, law enforcement is carrying them. Our state has done a lot in here where I'm at in South Carolina to have trained law enforcement officers carrying Narcan in virtually every law enforcement agency on almost every shift, and that's great. Again, we've got 50,000 people died from this. In 2019, something had to be done. For EMS, Narcan dosing, we've got a lot of options available. Depending on your level of certification, your level of training, auto-injectors, they typically are designed to administer 1 dose. You may repeat as needed. It may be a nasal injector. It may be a needle-based. It can also be administered IV via EMS providers, 0.5 to 1 milligram. And ideally, again, we want to do a very slow IV push on this. Now, typically, once we've given 1 to 2 doses of Narcan, if we're pretty sure that's what it is, we may need more in subsequent doses after that to not only repair respiratory effort, but also to maintain it. Another alternate I've seen via EMS, and this was taught to me by an old veteran medic, he showed me putting 2 milligrams of Narcan and naloxone into a 250 ml bag of saline. This gives him about 8 microgram per ml, and he piggybacked it in on his IV in order to be able to titrate it to respiratory effort. The goal is, again, we want to bring the patient down, but we want to do it as gently as we can. Overall, when EMS is administering Narcan, we need to remember that it's administered to correct the respiratory depression. It's administered to help them maintain their airway. We should always gently titrate it to avoid bad reactions. And in many cases, patients will be more willing to go to the hospital and more compliant with our treatment if we can treat them with respect and bring them down just enough to save their life, not necessarily bring them down so far that we send them into withdrawal. The average patient, especially someone who is chemically dependent, who's been abusing pills, if we bring them down so far to the point they're experiencing bad withdrawal syndrome, they're not going to want to go with us. They're not going to want to be treated by us. They're going to want to go out and try to find another fix. And unfortunately, the problem with that is, as we said before, Narcan works fast. It also wears off fast. And it wearing off that fast can be a major danger to the patient. The last thing we want to do is have a patient who decides not to go with us wander off trying to find another fix and end up dead 30 minutes to an hour later. That's not a good thing. Therefore, we need to, again, bring them down, titrate it to respiratory effort. We want to treat them enough, but not treat them so much that we put them into withdrawal. Now, beyond opiates, let's talk about pediatric poisoning. Pediatric poisoning prevention, number one thing we can do with infants and toddlers is keep things out of their reach. They'll put anything in their mouth. They don't know what's what. They don't know the difference between the pill, the hard pill that grandma dropped on the floor this morning versus a quarter versus anything else versus a chocolate chip. We need to keep any pills or poisons out of their reach, keep them secure. Child-resistant packaging can definitely be a big deal. Think about child-safing your purse. If you carry medications with you, whether it be just simple over-the-counter stuff for a headache or for allergies or anything like that, if it's not in a child-resistant container, what happens if the child gets in your purse and sees these pretty pink pills? All of a sudden, before you know it, they've taken an overdose of Benadryl or diphenhydramine. We also need to be careful with remote controls and some of the batteries that are in them. Children can also mistake button batteries, which many times have lithium in them, for something that's edible. Magnets can be a major issue for pediatric poisoning as well. If we have toys or things on the refrigerator that have magnets on the back, if the child actually eats the magnet, it can go in, it can cause all sorts of problems in their digestive tract, so we need to be aware of those. With older children, we need to keep prescription and over-the-counter medications secure. Also, if you have liquor cabinet in the house, you may need to make sure that that's locked up or that's secured. We need to look at transferring things into containers and be very careful with that. And what I mean by that is if we're using something out of a container instead of the one that it came in or the one that's labeled, we don't want it something that smells orangey fresh to be mistaken for orange drink when it's really orange cleaner. So things like that can definitely be a hazard to older children. Tide Pod incidents. There was a lot of talk about those, and I'm not going to say that a few kids didn't do it, but not too many kids were actually doing that. But if you think about things like what is, going on, a lot of this comes into just, prevention at home, keeping things up where people won't get into them. We need to be careful with e-cigs and especially vapes and the juice. The juice, although it smells fruity or may smell good or may smell minty or whatever the case is, those juices contain a pretty good amount of nicotine in them. Nicotine in those type of doses can be toxic. It can also be inhaled or ingested through the skin, so you have to be careful. If some of those juices are around, a child spills it or is sniffing it, and he goes to clean it up, he gets it on his hands, it can be absorbed through the skin and cause nicotinic receptors to actually light up on the child. Inhalants, things like contact cleaner, the spray cleaner for computers, things like that. Beware of those. Beware of, kids are using them, they're huffing them. Again, You shouldn't be going through your electronics cleaner, 2 containers a month, unless you're doing a lot of work at home. Maybe while you're, out of the house, your kids are playing with them. Again, we need to be aware of those. Possibly put them in a safe location, a secure location. Other things, we can look at environmental poisonings. Paint chips or scrapings, especially if it's lead-based paint, can be an issue. Dust from sanding can be an issue. Various lawn and garden chemicals, carbon monoxide, runoff as far as from garden or different spray cleaners. If we've been outside working with some type of spray cleaner or spray insecticide and we get a very light misting, could that run some of that insecticide off onto the grass? We also need to be careful with industrial facilities. And what I mean there is, if there's a closed factory or an old closed warehouse, maybe all the local kids like to go and play in it and explore in it and see what they can find. That sounds all kinds of fun. However, who knows what types of chemicals could be left in there or what could be going on in there. So again, beware of those. It's definitely, prevention is a big key with pediatric poisoning. The more of it we can understand how and where it happens, the better you as a parent or as a provider can be prepared to figure out what's going on with some of this stuff. In closing, toxicological emergencies can arise from almost any source at all. They can be accidental, they can be intentional, they can be a combination of both. Somebody can be trying to just get very, very high or get, very, very sleepy or do something and they may take too much. They may have forgotten they've taken something. In many cases, providers will be familiar with the substance involved, but sometimes it's not going to be there. That's where we can use poison control as a resource. Okay, this is what I'm dealing with. What is this going to do? How is it going to present? What do I need to be ready for on the backside of it? Again, we look at the opioids here. They represent a major problem. Over 70% of the deaths in our country that are drug-related are traced to opioids, at least in parts. And so therefore, Narcan should become more and more prevalent and accessible. Even Narcan has its limits. So again, focusing on that and prevention, of course, when it comes to the little ones, is worth more than all the remedy in the world. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.